Good morning, all of you. Thank you, Dr. Balamurugan, for this introduction. So let me say that today we know that we see ECG for every day, and it's the most common diagnostic tool what we have, and it's very common in patients with diabetes and heart disease is so linked. So I should just start with the case. This is a typical case which we see very often. This is one of our patient who was an elderly male, diabetic for 20 years, hypertensive. He's basically asymptomatic except for some occasional palpitation. There are no other symptoms. So no angina, no dyspnea. He's fairly alright with limited activities. He's come for regular checkup. And once he came, when he went to a diabetologist and he was taken an ECG, this was the ECG. This ECG shows you can see that it's a sinus rhythm, P waves are normal. There is a poor R wave progression. There is always an established Q wave from V1 to V4, which means the evolved anterior MI. So this patient was not having any kind of angina or symptom, but still has an evolved anterior MI.
Does he have an ST elevation, the ECG?
Yeah, there is some persistent ST elevation, mild ST elevation, but there is absolutely Q waves, complete Q waves are formed, which is an evolved anterior MI. So clearly, the patient is totally asymptomatic. He has complaints of occasional palpitation, nothing else. Elderly male, 20-year-old diabetic. So this sort of presentation is very common. Even one of my relative, we had a similar problem, came with a silent anterior MI, and we have lost the battle because the patient is already having LV dysfunction. Ejection fraction is only 35-40%, and now we have to check the viability, whether the muscle is really viable. And the patients, this patient particularly, we did a viability test, there is no viability. And we do an angiogram. You see, severe disease, the right coronary artery is essentially normal, but you look at the circumflex is also essentially normal. But see, the ventricular contraction is so poor, and the entire LAD is completely occluded and heavily calcified, diffused, totally blocked here. So this is kind of a common presentation of diabetes. We are lost. Can't do anything. This patient is on medical management. Can't do CABG bypass surgery or offer any angioplasty. So he's more restricted his life on medication for heart failure. Now, as his duration of heart failure advances, he starts developing symptoms also. So how you have to find out early. This is the most important thing. We know that 65% of all deaths in people with diabetes are related to cardiovascular disease. It's very huge, and acute heart attacks, MI, occur very often in young age, resulting in premature death. And diabetes mortality is up to 80% is related to coronary disease, 75% from coronary atherosclerosis, and 25% from peripheral vascular disease. And more than 75% of hospitalizations for diabetic patients is due to heart disease. So it's a huge magnitude we are dealing with. And even patients who are just newly diagnosed have 50% coronary disease. And particularly Indians, we know that Indians already have a high incidence of diabetes, but more than that, Indians also have higher incidence of coronary disease, particularly at younger age. The risk of heart disease begins at least 20 years before diagnosis of diabetes is done. That is because even in pre-diabetes stage, the risk of atherosclerosis diabetes increases. And it's up to 4-fold at 10 years before diabetes is detected. So it's very high. And 1 in 6 asymptomatic diabetic patients have severe heart disease up to requiring bypass surgery. So many of them are totally asymptomatic, still have heart disease. So my protocol of screening diabetic patients has extensively changed in the last few years. So diabetes also, pattern of disease is different in diabetes. It's usually multiple vessels, involves multiple blood vessels, involves diffuse, entire vessel is diseased from proximal to distal. Sometimes it is difficult to do a bypass surgery because of multiple diseases. More often occurs in a prematurely, very young age. And also women, the protection is lost in diabetes, you know that. And even if you do bypass or angioplasty stents, the outcome is not as good as in non-diabetes. So you can see this is a lady who had multiple lesions. So here you can see that one of the arteries is totally occluded on the left system, and the right you have, this is a common pattern. As an interventional cardiologist, I see the left system is occluded, the LAD is diffusely diseased, entire LAD from start to end is diseased. So this patient, fortunately, she was asymptomatic, but fortunately, we were able to see the viable segments, and it's all viable. So we want to revascularize and give whatever small collaterals are formed and still keeping the muscle alive. So what do? We send her to a surgeon for bypass surgery, but the surgeon said we can't do bypass because there is no target to connect the blood vessel distally. So we have no choice. Then so we had to. This sort of pattern is very common, and you know that this diabetes increases the risk even in a very early stage. The reasons, you know, that pathophysiology, we know that diabetes itself with insulin resistance and hyperglycemia can increase atherosclerotic plaque formation due to multiple mechanisms, endothelial dysfunction, platelet activation. So what we are dealing today is silent ischemia. I think that very often presents with very atypical symptoms. Even a muscular pain in a diabetic patient should be thought as a coronary disease and evaluated, because autonomic neuropathy is other factor which can mask the symptoms. And we saw that the prevalence of silent MI ranges from about 7 to 58%. It's very high. And with the study, the DIAD study has shown that even in an asymptomatic person, if you do a stress imaging, 22% of them already had heart attack. So it's quite a very high number. So resting ECG is a very, very important tool. You know that, but it's very widely used, very commonly used by all of us. And it's very simple to take. It's a non-invasive modality. So it's a first line investigation. But it can identify, like what I showed, a previous heart attack, silent heart attack, any arrhythmia, or even left ventricular hypertrophy associated with hypertension. So the sensitivity in detecting silent ischemia is limited. That is the problem, because ECG, even if it is normal, still patient can have severe disease. So resting ECG, 50% of them have normal ECGs. Let's remember that. And also, so if you have an abnormal ECG, definitely it indicates a worse prognostic marker. So any STT abnormalities indicate there may be an underlying heart disease, but also remember there may be also many non-specific STT changes. So sometimes the specificity is also a problem, because high false negative range also limit them as a specific screening tool. So ECG has got limitations. We know that the sensitivity and specificity of ECG, you can see that. So the sensitivity of various ECG, exercise ECG versus other tests I have shown, so much of limitations are there. But you have to look for this kind of Q waves, particularly in even asymptomatic persons who have this inferior Q wave suggesting a silent inferior wall MI in this patient. And the anterior wall changes here. You have the ST elevation in inferior leads and also reciprocal ST depression in the lateral leads. So these are the patterns which is commonly seen. And if you look at this Spanish study, in asymptomatic patients, if you look at normal versus abnormal ECG, you look at this, many of them, the patients will have abnormal changes, but still significant of them number will have normal ECG. So both are very important to look at. There are limitations of ECG because, as I told you, normal ECG doesn't rule out coronary disease. Still, patients can have coronary disease, and so that is a limitation. So I'll show you some few other cases. See, this is again a patient with a 57-year-old male, diabetic, asymptomatic, totally asymptomatic, normal, everything was normal except for treadmill was positive. ECG looks absolutely normal. So please understand that even with symptoms, the patient comes with symptoms. If he doesn't, normal ECG doesn't guarantee that he doesn't have underlying CAD or even acute coronary syndrome. ECG takes time to show up. Changes come after some time. So ECG is a very poor, reliable test to confirm that patient has coronary disease. So this patient subsequently turned out to have significant severe CAD, and this patient underwent bypass surgery. So let me show you another case. This is a lady, elderly lady, already is a known coronary disease, diabetic lady, but she was asymptomatic. 2001 she had a stent, and since then she's been doing very well. Completely asymptomatic. She went for a routine test, went for a calcium score. ECG was normal. See, ECG is like this is very often these patients. And she went for a routine calcium score which showed a CT calcium score of 1927. See, calcium score is again a very useful test to identify higher risk patients, and this indicates that above 400 is very high score. Patient underwent coronary angiogram, and then this patient also found to have severe disease in the LAD, underwent bypass surgery. So I'll show you one more case. This is a 55-year-old lady, diabetic, 25 years, and this patient has abnormal rest ECG with the Q waves in anterior leads, again a silent anterior wall MI, LV dysfunction. By the time the LAD is totally occluded, and we had to work on this LAD with multiple drug-eluting balloons. This finally we do that, and we open the LAD with stents and with drug-eluting balloon. So these are all difficult to treat when they come very late. So we can identify early. There are many markers. We know that there are risk stratification tools like Framingham risk score, the Q risk, UKPDS score. So we were actually, we published this article along with Dr. Mohan, Mohan Diabetes, and Dr. Anjana, and you can see that the value of the Q risk and FRS were good predictors to identify cardiovascular disease, particularly in Asian Indians who have both type 1 diabetes and type 2 diabetes. So the number of alternative modalities like stress testing, like treadmill, which we often do, but the ECG, exercise ECG has limitations. Again, it is very poorly sensitive and specific. Other we can do stress echo, nuclear imaging, stress thallium, and also the calcium score. That's a very again useful test. And of course, finally CT iodogram and coronary angiogram. So CT angiogram is it's very useful because it can clearly tell where the block is. The calcium can be identified. The length and the location of the block can be identified. But the calcium score is an easier way to identify, and one can use it in high risk patients. So I'll give you a flow chart on how do we identify asymptomatic patients even if their ECG is normal. So you can have a stepwise approach to screen these patients to diabetic patients. So it's very important to select appropriate tests because it should be cost effective based on the individual risk profile, because we know that we can't do all the tests for all the patients, all diabetes. So identify, is there how many risk factors are there? If the patient is as a diabetic who is aged more than 35 to 75 years, then look at the risk factors. The first table is very high risk. At least even one of the risk factors are there. Like either there is a previous heart disease, or LDL cholesterol more than 190, so they are very high, or it has albuminuria more than 300 milligrams per 24 hours, or the eGFR is low, or if you have abnormal Q waves, I showed you silent MI, or if you have echo which shows LV dysfunction or abnormality, or if there is peripheral vascular disease. Very important, because we have peripheral vascular disease, almost always patients have coronary disease. So these are all indicators that this patient should, even one factor is there, then we should know that this patient is high risk. If it is not there, then there is additional high risk, very high risk, at least 2 should be there. The diabetes duration of more than 10 years. Or if there is a premature coronary disease in a first degree relative, which is very often we see that. First, premature means male less than 50 years, women less than 60 years. So premature coronary disease, or if there is an uncontrolled risk factor like high cholesterol or low HDL, or there is smoking and history of hypertension, or there is confirmed albuminuria, microalbuminuria, or if there is associated diabetic complications like severe retinopathy or autonomic neuropathy, or the patient is very sedentary and very having highly symptomatic on small low physical activity. So this is very common. You will find the patients with diabetes more than 10 years along with the patient who is not able to walk, not physically active. So it's 2 factors you already identified, very commonly see. So these patients should be subject to calcium score. Why I am telling this is a huge magnitude of patients which you are all seeing, and these patients we can miss the CAD unless if you don't identify those risk factors and subject them to calcium score. Calcium score is a much more simpler test than a CT angiogram. So it's essentially a simple step. You want to go step by step, then calcium score is easier, less radiation, quickly available. The calcium score gives calcium score like it can be from 0 to 400, above 400. Generally above 400 is very high risk. Less than 100 is very, very mild. We generally have to keep him on medication. Don't even have to do anything. Just give statin along with aspirin. Aspirin, again, you can start if its calcium score is more than 100. Generally, at less than 100, again, we don't even have a role for aspirin. So, calcium score is a simple test to get it done. And if the calcium score is more than 400, these patients should be go for further evaluation, like again either a CT angiography or a coronary angiogram, or referred to a cardiologist. So I think based on resting ECG, it is impossible to make any conclusion on the status of the patient just by doing that. So identify the risk factors. If the ECG is abnormal, then you know that you identified. But even if the ECG is normal, you have to find. What about the guidelines say? The ADA doesn't recommend routine screening, but ESC definitely says identify the high risk patients who have additional risk factor, and then you do screening. So identification of high risk factors are important. So with these messages, I would like to conclude that people with diabetes are at very high risk for coronary disease, and early diagnosis by subclinical identification of coronary disease is life-saving in several patients, and very important to identify high risk factors like the age, duration of diabetes, high cholesterol or associated other risk factors like smoking or high blood pressure, and the presence of vascular disease elsewhere, if there is a carotid vascular disease or a peripheral vascular disease, that also is use ECG. Of course, is a very, very important tool because it can be initial, easily available resting tool. If it is abnormal, fine, you have identified, but if it is normal, you have to proceed to risk identification, risk factor, and the risks are high, you have to proceed for advanced imaging and further cardiac evaluation. Thank you very much.